Hey, welcome to my podcast. My name is Dr. Brendan McCarthy, and I am the Chief Medical Officer of Protea Medical Center in Tempe, Arizona. Thank you for tuning in my podcast. It's a beautiful day here in Tempe. I love it here in the wintertime. Summertime is super hot. It's like 120 degrees Fahrenheit, which is like what? Like 50, 48 degrees Celsius? Is that crazy talk? I don't know. 50 degrees Celsius seems not. It's been a while since I've lived in a country that used Celsius as its indicators. Anyway, I have. All right, I've done that. I've done my due. I'm not as I've traveled a little bit here. I've gotten out of my shell, so to speak. Anyway, today we're doing menopause, and it's such important material. And today we're talking about treatment. I had to change this so many times in my head how I was going to do this with you. Before I do, though, as always, whatever platform you're seeing us on, there should be a subscribe button. Do me a favor, just this moment, subscribe. And if you like what you see, please press like. And if it would help someone else, please share this material. Our job is to be of service to you, to be helpful. I'm never going to sell you something. I'm not selling you something. And I'm not trying to get you to come into my office. I'm not here for the wrong reasons, guys. A lot of times you'll get material on these places, and it doesn't always mean it's bad material, but it's always questionable to me when someone is coming out here and talking to you, and then, by the way, here's one of my supplement regimen I'm selling you on the side. I believe this is a calling, practicing medicine. I'm very fortunate to have had the years that I've had doing this. I'm blessed. I'm blessed. I really am. So let's get into the material. Let's discuss this menopause and how do you treat it. This is part 2 of the treatment section. So we've been doing a few episodes today, knocking this out of the park, Justin and I. Today we're going to get a little bit more detailed into treatment. Last time I talked about the fears around treating menopause, because there are a lot of fears out there. I went a little bit more into cardiovascular, but I'll talk about oncology with there too. But the fears around it really need to be dispelled. So that's why I made it a little bit longer than we normally would. This one's going to be really the nuts and bolts of it, and the meat and potatoes. Where I get into that part of I need to be thoughtful is that 20 plus years of practice has taught me what therapies are the safest and best to use. I know what I use. I know what it does. I could tell you what every hormone I give you will do as it gets metabolized through your body. I know where it'll get hung up. I know what to expect with your labs. I know what to watch for. I watch all of it because that's what I do. This is what your doctor should do. I know it's not common anymore, but this is what it should be. And this is what I want you to deserve. Not that I want you to deserve. You deserve and I want you to get. That's the truth. When you go to your doctor and your doctor will prescribe you hormones, there'll be times when you can't do the protocols I want you to do because the doctor doesn't have the same level of experience. The medications I'm going to recommend are not widely available in your area or your country. That doesn't mean that the other therapies you're going to be doing are going to be useless or necessarily bad. They're just not optimal. And there are things we have to watch for if we do them. And I'm going to discuss that with you today. Because there's no perfect way of giving a woman hormones. None. Because it's coming from the outside in. Whenever you give someone anything and you're going from the outside in, you are changing the parameters of how it's normally released. Your ovaries release estrogen and progesterone in a rhythm. And I'm giving it to you from the outside in, and your body's like, what is that? So the pathway of getting into your body to there, I need to understand all the steps that are involved in that when I prescribe. Different delivery mechanisms have more side effects than others. They're manageable, but it's important to know what they are. So I'm going to make sure I give you that data. So woman comes into clinic. I've diagnosed her as menopausal. She needs estrogen. How do I do it? What am I doing? Giving her estrogen. There's 4 ways to get into your body. 4 ways. The most common one you're seeing out there in the market right now in the States is topical. And the topical can come 2 ways. It can be a cream or a patch. Okay, patch is good, but you know that up front. Cream, tricky. You put the cream on your skin, and first of all, it's going to be a good method to get in your body when it comes to side effects and adverse. Topical is going to be your safe one of your safe ones. So a woman puts on the topical, and she's good to go. The problem is when you put on a topical, no matter how hard you try, you will transfer it to people around you. This is essential to know this. So if a woman has no other choice but to put on a topical, and she's in a place where she's living where this is it, this is all my doctor can prescribe, this is all the compounding pharmacy will make, is just this cream, this is all I got, Brendan, what do I do? I advocate for them to put the topical on and leave it on their skin, and to be very careful because their clothing, it'll wick to their clothing. And so if they put their clothing in the hamper and they wash it, you're good. But if somehow or another the clothing is, their husband handles it, this happens. You're getting on him now. So it's important to make sure you understand that anything that may have gotten that cream onto it has estrogen and can get onto that other person. You don't want to put it on a part of your skin, like if you put it, say, under your arm here in the antecubital crease. If you put it in this little area here, you give someone a hug, it's probably going to get on them. If you're going to put it on this part, probably get on them too. You don't want to put it on a place where you're going to touch someone. What about when people do it transvaginally? Don't do it. This is published. I'm going to read it so you understand this. Men absorb vaginal estradiol during intercourse, whereas intercourse reduces estradiol absorption in women. Although serum estradiol levels were mildly elevated in men, it is possible that long-term exposure can cause feminizing changes. In women, estradiol levels were markedly reduced by intercourse. When you put a transvaginal estrogen in your body, transvaginal estradiol, and you're having intercourse, just know your husband's penis or your partner's penis will have estrogen on it. That is not a good place to put estrogen. It is not good for his penis. It doesn't work well with it. We, as men, we need estrogen, but this is a bridge too far. So no matter what anyone tells you, this is a truth. This is a truth. And if you don't agree, I hear you. I would say, please test it then. Do test. Test your husband before and after you start using it. Test your body when you use it transvaginally with intercourse versus like on your thigh or in your here. See how much you're actually absorbing when you're transvaginal. This is so important because many of you apply transvaginally. This is the thing. Women want to apply transvaginally, and clinicians want to do this, and pharmacy want to do this because a lot of women have the side effects of low estrogen causing vaginal dryness, urinary tract infections. They're going to have pain with intimacy. If you're doing your job well as a physician, I'm going to say this out loud. If you're doing your job well as a physician, you don't need to put it topically, topically vaginal. Because if you put it here, it's getting in their body. It's systemic. It's going to do the work from the inside out, which is what it's supposed to be doing. Estrogen to the vaginal wall, to the tissue there, comes from circulation, not from skin. So if you're putting it here, it's getting enough into circulation, it's systemic doing its job, it's going to be enough that's going to do that job there as well. There are exceptions, I know this. So topical, please know, you're going to transfer it. There are better ways of doing it. If you have to do it in a place that you're not going to get it onto your partners or your friends or anyone around you. It's so important you do that because you don't want to contaminate other people with this. You don't want to change someone else's health doing this. So topical. Oral estradiol is not safe to do. Oral estradiol is not safe to do. When you take in estrogen orally, I'm going to say this, if you have to do it, you have to do it, but just please be so careful with it. But I still say don't do it. Get it on a topical. Do a patch. Patches don't have the transfer. Patches are wonderful. When you do it orally, estradiol, you're going to cause us a few problems. One of the problems is going to be you're going to increase your body's thrombin. You're going to cause your body to want to clot more. Estradiol, when you take it orally, gets hyperconverted estrone. Estrone stimulates thrombin. You have a higher incidence of venothromboembolic events. Okay, we don't want this. Oral estrogen causes clots. So we want to avoid that. If you have to do it, we got to run our labs around that. We run your estrone levels. We run all those clotting cascades with you. If there's no other choice, we would do that. That's what we have to do to keep you healthy. Because otherwise you're starting oral estrogen. That's not good. It's not good to have those symptoms. What else can it do orally? Oral estradiol, when you're taking it orally, your liver doesn't understand that because you're eating it. Your body's thinking of it as a food, so it goes through digestion. It goes absorbed as if it were food. Your liver's like, this is not food. And it's your liver treats it very differently. So the first thing that happens when you take in estrogen orally, you're going to have an uptick in estrone levels. Now, estrone, as I mentioned a minute ago, that stimulates thrombin. That's going to be a risk factor for clotting. Okay, yes. But what else is it doing? Oral estradiol is going to increase something called sex hormone binding globulin. Sex hormone binding globulin is a protein that sequesters your androgens, specifically testosterone. So if your sex hormone binding globulin has become elevated from oral estrogen, you will take all your testosterone out of the equation, and that will cause you to have, among other things, low libido, reduced muscle mass, blood sugar metabolism will not be as good, insulin sensitivity won't be as good. You need testosterone. So orally has that impact as well. What is the one I use most clinically? In my practice, is going to be injectable. I like it because it's a once-a-week injection. You do it every 7 days. I run my labs. You don't transfer it on to anybody. It stays in your body. I watch for the conversion. You don't have that same conversion to estrone. You don't have the same problems with sex hormone binding globulin. You are going to be inside the body, benefiting the body directly because it's in circulation the way it's supposed to be. So I prefer doing estrogen as estradiol cypionate. That's my preferred method. The dosing that I use with women with estradiol cypionate when I go down that road, I use 0.25 milligrams to 1 milligram every 7 days. I know the insert, as I mentioned earlier, does it once a month, but when I do it every 7 days, that dose seems to work really well. And we use lab work to verify. And when we do lab work post therapy to make sure I'm in the right range, I try and keep their estradiol somewhere in the neighborhood of about 100. 80 is fine. Now, if I'm below that, I know that I'm going to be running risks with bone loss because the further you move below 80, the higher the risk factor is for bone loss. If I'm using other therapies like testosterone replacement therapy and to a lesser degree progesterone, I will be able to maintain bone density with those guys at a lower level of estrogen. That's possible, but the lab work helps verify what I'm doing is maintaining bone density. We do labs to see if you're spilling bone. We also maybe do a DEXA scan to make sure we're doing well with maintaining bone density. So the dosage here is a little bit something I kind of fiddle with, and I at the reference ranges, I'm going to move around a little bit after providing that injection to make sure I'm hitting the correct spot. The final method delivery that we do is going to be estradiol as a pellet. Now, pellets, that's been around since the 1940s, and it comes and goes in popularity. It was big in the 1970s, went away for a while, came back. Gino Turturro is an unsung hero of medicine, great guy. He hero, definitely, what he did with women's health. He brought back a lot of really good therapies for menopause in the late 1990s, early 2000s. And he brought back pellets, and it became very popular again towards the 2010 area. And then it kind of went down, and now it's coming back up. So it's come and go. With that said, when you're doing pellets with women, the pellet is going to be there for a total of 4 months, and you're committing to that. If you put a pellet in and they don't like it, they can't get it out. They're stuck with it. They're going to be stuck with it for the whole time. So you want to make sure that you know what you're doing with dose, because if you do too much, you can't take it out. Too little, you can't. You can add, but you're doing another surgical procedure to put it in there. And when you do it, you want to make sure that they are comfortable with this. So a lot of times, if you're going to do pellets, you want to do maybe injections for a few months to verify that they're okay with this. They like the way it feels. Is this going to be helping with their symptoms? And then maybe you transfer over to pellets. That's possible. All those things said, the pellets are considered very safe, minimal side effects as long as you're doing a clean procedure. It's the size of a little chip of estrogen, it's very small, and it's inserted subdermally. Very easy procedure. It's done within 15 minutes in office, and it heals very easily. Those are the ways I would deliver these hormones to women, and the reasons why I would deliver them, and et cetera. This is my approach to menopause with hormones, the estrogen and progesterone. I would be not a good doctor if I didn't talk about the other things we use as well. There are times I need to use testosterone. There are times that I need to use other pathways, because sometimes with women, they can't do estrogen. Sometimes they can't do progesterone. There's different reasons why women have different needs. I'm not a one-trick pony. I want you to know these videos we're putting here are just me doing the basics of how to treat. The impact estrogen has on brain chemistry in women is powerful, and progesterone is powerful. And when you've these are moving around, you need to be aware of that. And you need to know that when you're treatment, if you're too far off, you're going to make their symptoms worse a lot of times. If you're too high or too low. So you're going to make sure you're very careful with when you treat them with this. Even so, sometimes you get the numbers perfect with their labs. The dose is great. Most of their symptoms are gone, but they're still not feeling right emotionally, mentally. It's important to know how to run further labs. What are their monoamines? Are they having trouble making serotonin? Do they have enough precursor? Does their body not methylate? There's a lot of questions you have when you treat these women with menopause. You can't just be the doctor that says, well, just give you estrogen and progesterone. And if that didn't treat it, well, then too bad. No. You want to make sure you understand the woman in front of you completely. And running labs is the first step, and having an open mind is another one. I hope this helps. This is important material. It's important I get it right. If there's something missing, you need more information, make a comment. Let us know. Our next episode is going to be questions and hopefully give you answers to your questions from the things you tell us. So if you're seeing this on Instagram, put a comment in here. Our next episode that we're going to drop on YouTube will be answering the most common questions. We'll try to go through them like we did with the PMS one. All right. Thanks for tuning in. I hope you have the great rest of your day. I know I will. I'm going to go out with my kids and have a nice lunch. And I'll see you at the next episode.